Good morning, everyone. We're about to begin. We do apologize for the late start, but we know it's raining a little bit outside, but despite that, you're all here. So thank you very much for coming. So I want to, first of all, welcome our distinguished plenary and panelists. This morning, we want to welcome all of you, our HRSA grantees, our HRSA personnel who are here today, invited guests, and friends of the National Center for Health and Public Housing. I do want to recognize also our public housing authorities and our residents in public housing. We welcome all of you today to the 2012 National Primary Care Conference for Health and Public Housing. This year, our theme is raising the bar for healthcare for residents in public housing. And so we are truly delighted for all the work that you do. You have done tremendous work over the past year, and we want to continue to make sure that you continue to be successful and raise the quality of care that you provide for residents. I do want to say a special thank you to HRSA, the Human Services and Resources Administration. I'm sorry, I'm sure I said that incorrectly. Let's try again. HRSA. The Health Resources and Services Administration, for funding our national corporate agreement. The National Center for Health and Public Housing is a project of North American management, and we are funded by HRSA to provide training and technical assistance for all of our public housing health center grantees who are serving residents in public housing. This has been a remarkable program, especially for so many hundreds of thousands of residents in public housing. So we do recognize that this is a valuable program in many of the communities that you serve. We have grown tremendously over the past year. Last year, this time, we had about 55 public housing primary care health centers. This year, HRSA has actually funded 8 additional ones. So we are seeing some growth in the public housing primary care program. We're really proud of that. And we will continue to see, yes, I'm sorry, forgive me, my voice is giving me a little problems. But we welcome this type of growth. We know it's a needed program, and we hats off to HRSA for recognizing that and continuing to support the special populations. So today we want to also recognize our H. Jack Geiger awardees. These are our grantees who have done a tremendous job in accomplishing HRSA's priority goals of program management, performance development, and analysis, and performance improvement. So at some point today, please reach out, connect with them, congratulate them, and find out what they're doing in their communities, because each one of these programs is doing something remarkable and different. So we want to congratulate all of our awardees. I do also want to thank all of our sponsors and our exhibitors who have also added to the success of this conference. So feel free to visit their various booths outside. They have tremendous resources and services to continue to strengthen your programs and support you. And last but not least, I must recognize our hardworking and dedicated staff. I want all of our staff members to please raise their hands. These are the folks who have worked tirelessly to put this conference together. And so I really appreciate the staff and all the hard work they have done. Many of you have gotten tireless calls, but this is what we do. We are there to assist you. And please interact with them during the course of over the next 2.5 days. You're going to be hearing from some phenomenal plenary speakers. You're going to learn a lot through these amazing workshops. And remember that there are CEUs attached to them, so you will be able to get your credits. We look forward to, we want you to have fun, enjoy, and feel free to ask anyone questions. Okay, so thank you again for joining us. And I'm now going to turn it over to this morning's moderator, Mr. David Vincent, who knows almost all the grantees in this room over the past years. Thank you.
Thank you, Dr. Webb. So nice to be with you guys this morning. So many wonderful old friends that I see, and look forward to meeting some new friends here today. So I have the pleasure of introducing each of our wonderful plenary speakers today, and I get to start with Dr. Brandt. So Dr. Brandt is the Deputy Administrator of Health Resource Services Administration, which we fondly call HRSA. From 2001 to 2007, Dr. Brandt was the Director and Associate Administrator of HRSA's Office of Rural Health Policy. In that position, she was responsible for health policy, research, and grant activities that promote better health care services in rural America. From 2007 to 2008, Dr. Brandt was the Associate Administrator of HRSA's Bureau of Health Professionals, where she provided national leadership in the development, distribution, and retention of a diverse, culturally competent health workforce that provided health care. It's my pleasure to introduce Dr. Brandt.
Thank you, Dave. Can I shut this? Great, and good morning. Thank you, David, and thank you, Astro. And I want to thank you for this invitation, and I also want to thank you for not scheduling my presentation for immediately after Congressman Davis's presentation. This year, he is arguably the most articulate, engaging, and passionate speaker about the issues you care about and we care about. Blissfully, I'm before Congresswoman Edwards, and I'm sure she's equally as good, so I lucked out today. I think it's really important to know your audience, and frankly, I have been wondering about you. This is the third time you have invited me back. And I look around this room and I see lots of the same folks, and I'm just curious about what keeps you so engaged. Because arguably, you have the most challenging work of any of HRSA's stakeholders. HRSA's mission is to serve the medically underserved, the most vulnerable among this nation, of the people in this nation. And in 2012, HRSA will invest about $8.2 billion in 80 different really great grant programs. Including you, we have about 3,000 or so partner organizations. So here is what I think I know about you. I may be wrong, but I think you are not afraid of a difficult challenge. You look at the 8.7 million residents who are in public housing, and instead of hopelessness, you see the opportunities to make life better for the people you care about. You look at the disparities data about the differences in health status between the residents of public housing and the general public, and you don't think these things just can't be changed. You think, how can I change them? You look at poor nutrition and the unavailability of healthy food options in these communities. You look at the higher rates of obesity and diabetes among residents. You don't think people choose that lifestyle. You think, okay, we need a safe place to walk. We need a farmer's market. And we need to rethink the potluck with its unlimited fried chicken, mac and cheese, and dessert tables. You look at the 23% of the residents who are missing 6 or more permanent teeth, and you don't go, just like that. I don't know about you all, but where I grew up, that was the ultimate sort of condemnation. Those 3 notes, No, that sort of meant, what a shame. So you look at these folks with missing teeth and dental pain, and you think, how can anyone get a job looking like that? Or how can anyone be a good student or a productive worker with that pain? And you set up dental clinics, or take the neighbors to the university dental clinics, or badger local dental providers to see these folks. You look at the higher rates of smoking, 28% of residents compared to 17% of the population, and you find a way to offer smoking cessation clinics. And you look at the grinding poverty. 82.5% of your residents are below 100% of the poverty level, and 96.7% are below 200% of the poverty level. And you don't say something biblical like, well, you know, the poor will always be with us. You say, these kids are going to graduate from high school, or this guy is going to stay sober and keep that job, and you work with the schools and the addiction counselors. So what I think I know about you, and I could be wrong, I think you are incredibly resourceful, tenacious, committed, and maybe just a little bit crazy. because you are still here and you should be so proud of the mission that you have chosen. And there are folks who want to partner with you and sort of share that madness. And so I want to talk a little bit about support for the health centers and your program. HRSA funds the health centers and grantees to work with you to provide vision services and oral health care. They create outreach toolkits for residents. Another example of working with you in the madness is the award to the Community Health Partners for Sustainability, which provides assistance to new public health primary care sites, monthly newsletters, action alerts about funding opportunities or policy issues, and seasoned veteran peer counselors. We're also trying to work and collaborate across the department with other federal partners like the AOA to improve health outcomes of seniors living in public housing. So HRSA has strengthened its collaboration at the federal level to increase access to quality care and improve outcomes of residents in public housing, including our work with the AOA. And in 2011, we led a cooperative agreement to the North American Management Association Health and Aging Project, and they're working with the Administration on Aging to deliver information in the form of training, webinars, and yesterday's first annual conference. It's convened to address the healthcare needs of the elderly across the U.S. with a focus on health centers as a safety net provider. So we are hoping that you will be able to work directly with AOA and the agencies who help you monitor and provide care through the health centers to seniors. We also think it's important not just to reach across HHS with our other sister agencies, but also to work with other cabinet-level departments. And so I'm very pleased to be able to share with you the fact that Secretary Sebelius, HHS Secretary Sebelius, and HUD Secretary Sean have discussed the association between housing and health, and frankly released a joint commentary entitled Poverty and Opportunity, posted in December of 2011. They talked about the connection between people's homes and people's health. The New England Journal of Medicine recently published the results of Moving to Opportunity, a study showing connections between health and housing at the neighborhood scale. We looked at 4,500 very low-income families living in public housing projects in high-poverty neighborhoods in 5 cities, and the study found that very low-income women who had the opportunity to move from high to lower poverty areas are significantly less likely to be extremely obese or have diabetes. So what that means to you is that you get to help these folks bridge their movement from public housing to a lower poverty level kind of housing. We have, I think, over the past couple of years, well, since 2009, made incredible investments in health centers. And so between the Recovery Act, which seems like so long ago, but was so much work, and the Affordable Care Act, we've really made enormous investments in the safety net, expanding access to primary care and preventive care. And since the President took office, the number of patients getting care at health centers has grown by 2.4 million. That's 19.5 million patients getting care in more than 8,500 sites. And I want to get specific about some of those investments, and then also talk with you a little bit about what you can anticipate going forward. So since 2011, HRSA has funded $40 million to establish 67 new health center sites. Of these 67 total awards, 11 went to public housing grantees. We've also released about $32 million in 904 community health centers, and these provide assistance to existing health centers as they try to achieve recognition as patient-centered medical homes. In a medical home, you plan, support team-based models of service delivery and systems upgrades. And recipients of these awards included 42 public housing grantees, and they got the dollars for the patient-centered medical home. In some ways, you all had already figured that out, that chronic disease management needed to be done to improve health outcomes. Another 8 of the public health grantees received Health Center Capital Development Awards. In all, we spent about $732 million for 144 such awards for construction and renovation projects. And we've spent about $50 million last year for school-based health center capital grants. And so, as you know, we've made a lot of investment between the ARA, and the ACA. Given the challenges that you face, I think you might be interested in what's coming next in terms of resources. So let me talk a little bit more about the investments that the ACA makes in you and in health centers. We will have about $150 million to establish 220 new health center access points, and we anticipate that the awards will be made this summer and that we'll be able to see about 1 million more patients. We anticipate awarding $20 million more to support the adoption of electronic health records and other health HIT, and that funding announcement is imminent. So you watch your calendar, not your clock, okay? Expanded services, there will be about $15 million more to support the expansion of health center services, particularly for HIV and AIDS, which I know is a population that you all work closely with. Okay, this is the announcement for which you can watch your clock, your watch, and not the calendar. $600 million in health center capital development. Building capacity for the program will be made to about 125 to 150 health centers to improve their capacity to provide primary and preventive health services. Another $100 million will be made in health center capital development for immediate facility improvements. And since I really enjoy this job and have no intention of scooping the administrator or the secretary, that is as much as I'm going to say. But you get my drift? So this could be a good day. So I want to close on a fairly positive remark. Obviously, we will be successful in doing our work as you are successful in doing yours. And so I would want to encourage you to share with us your ideas about how we can do our work better and how we can help you do yours better, because I think we have a tremendous opportunity to address the challenges here. And frankly, we know that you are not afraid of a challenge. And you are incredibly resourceful, tenacious, committed, and just my kind of crazy. So thank you very much.
Dr. Brandt, thank you so much. It's always a pleasure to see you, and we so appreciate you coming here out of your busy day and helping lead this effort. Thank you so much. Our next plenary speaker is Congresswoman Edwards, who is with Fort Washington. She represents Maryland's 4th Congressional District, comprising of portions of Prince George and Montgomery counties. I actually have family in there, so thank you for representing them. And she was sworn in as a member of the U.S. House of Representatives in the 110th Congress in 2008, and she began her first full term in the 111th Congress in 2009. Representative Edwards has enjoyed a diverse career as a nonprofit public interest advocate and in the private sector on NASA's Space Lab project. Prior to serving in Congress, she was the executive director of the ARCA Foundation in Washington, D.C., and was also the co-founder and executive director of the National Network to End Domestic Violence, where she led the effort to pass the Violence Against Women Act of 1994. That was signed into law by President Clinton. So it's my pleasure to introduce Congresswoman Edwards, please.
Thank you very much. And Dr. Brandt and I had a little bit of a conversation beforehand, and I shared with her that she got to give all the good information and get people very excited about the details of health reform and what that means, and all the work that HRSA is doing. And I get to get up here and I have the easy part. I get to give the rah-rah speech. And so in that, my first rah-rah, though, has to be to HRSA and to HHS. I mean, it has been amazing to see that since the passage of the Affordable Care Act, prior to that, the American Recovery and Reinvestment Act, the stimulus package, that this administration really from day one has been focused on how to reinvent government services and provide care to the most needy and underserved communities and population. And it's amazing to see the amount of progress that's been made over the last almost 4 years. And so that's about as political as this speech is going to get. Because I think it's important to value where we were and where we are right now. And Dr. Brandt has laid out over the course of these next several months and years where we're going. And that's why we're all here today, because we know that the populations that we serve are sometimes overlooked. I think about the district that I represent, which frankly is not all that different from a lot of districts across the country where we have, and we're fortunate in Maryland, I will say this, so Maryland, because our governor wouldn't let me get out without saying it, Maryland has the #1 schools in the country for the 4th year in a row. Maryland's unemployment has remained significantly below the national unemployment levels across this country, even through a very difficult economy, and even though there are Marylanders who are suffering. We just found out that Maryland has a higher per capita number of millionaires than any place else in the country, and we're a small state. Okay, so what that means, though, is that in districts like the one that I represent, populations that are really in need can sometimes be masked behind that kind of wealth. That it becomes easy to be behind our gates in our gated communities and in our fancy jobs and, you know, shopping at great places where we can buy yellow shoes. And we forget sometimes that there are populations that have tremendous need and communities and people who work hard every day but still live below the poverty line and still need services and still need health care. And so I want to thank the administration for not allowing districts like mine, states like mine, and all across this country, not allowing us to forget that we still have a lot of work to do. And that goes to you as well. And so let's think about that. I mean, I also come from I live in a county where a young boy several years ago, his name is Diamante Driver, many of you know his name because he was a poor child living with a mom who couldn't afford to take him or find dental services, and at, I believe, 12 years old, he lost his life because he had an abscess and couldn't get care. That is in a county that has some of the highest per capita incomes in the country. And so we have to remind ourselves over and over again about what the need is and where our work is. And so I think about where we want to go, and Dr. Brandt has laid that out, and she said to us the challenge is making sure that we have this sort of robust development of community health centers across the country that are providing health care services to people where they are. Those of you who've been community health providers in public housing, what you know and what you've always known is the importance of being in a community and providing services in that community. This is something actually rather new for us on the national stage, that all of a sudden we have an orientation in healthcare that's about community-based healthcare. And that means wherever those communities are. And if those communities are in public housing and improving the day-to-day living of those who live in public housing, because it's that kind of foundation that gives people a leg up. It's that kind of foundation that enables people to see their prospects in a different kind of way. But if you are in public housing and both worried about the housing that you have, now you're not homeless, you do have some place to live. Dr. Webb and I talked about this, that we have, plenty of people who have some place to live, but they're still poor. They have need of health care. They still work. They have need of food services, but they still work. They have need of being able to buy fresh fruits and vegetables on a corner in their community. And not just leave it to all of us who live in fancy neighborhoods to have farmers markets. We just worked with some groups in our community over in Prince George's County, just across the river, and I want to thank Mayor Yulee for allowing us to be here in Alexandria. But in Across the Wilson Bridge and the Potomac River are communities where inside of the Beltway perimeter here in the metropolitan area are deep pockets of poverty. And it took a community coming together to say, you know what? We actually do want fresh fruits and vegetables that are affordable in our community for people who live there, because we want to improve our health prospects. And we may live in public housing, but we don't want it to have mold. And we may live in public housing, but we still want the trash off of our streets, and we don't want just fast food restaurants and liquor stores in our neighborhoods. These are the things that it takes really to build community. And I think part of the reason that we are here today is to say, what is it that we can do at the federal level that really empowers states, empowers local communities, empowers advocates to serve their populations. And we recognize that just as in my district, we have many diverse populations to serve. When I look at your agenda actually recognizes the diversity of the population that you serve, whether you're talking about seniors and children and those who speak different languages and come from different cultures and are new immigrants, and some are not, people who maybe for generations have found their families for lots of different reasons living in public housing and being served by the services in those communities. And so we have a whole range of different populations. Well, our services have to begin to reflect that and have to be sensitive to those needs. I was working recently with and I'm not going to give a pitch, but there's a group. You say I'm not going to give a pitch, but there's a group over in Prince George's County, Maryland, that serves the Latino and Hispanic community. And they want in their community to provide community-based health care right there in their neighborhoods. Language-sensitive services, culturally sensitive services. We ought to be able to find a way to deliver those kind of services in all of our communities. And these are in neighborhoods that are incredibly distressed in a whole range of different ways. But I also know, I think that there are things that we can do at the federal level. We can actually expand. Not everybody who needs services and is in an underserved population is homeless. Some people have homes, but they still do need the benefit of those services. And so it's not going to be up to Dr. Brandt, but it certainly is going to be up to people like me, members of Congress, to expand the availability of the resources that we do have, even in a constrained economic environment, to provide those services where people are. And I don't know, I think around this country, I'm one of these, and I hope I share this in this room, I'm actually really excited about the Affordable Care Act. I mean, I am so excited that I can jump up and down about the Affordable Care Act because it was the right thing to do, and this administration is implementing it in just the right way. It's saying, where are folks? Who needs health care? How can we get that to them? Some of you know, because I've shared this before, I remember when I was working every day and didn't have health care. And I had some place to live, but I didn't have health care, and I got really sick, and I went into an emergency room, and you know, it was really expensive, and it almost sent me under. There are families like that all across the country. And although we've expanded Medicaid eligibility to 133% of the poverty level, Astral has shared with me, and I know that you recognize that the populations that you are working with are 200% below the poverty level. And so there are deep needs out there for the public housing served community. In Montgomery County, which is one of our wealthier counties in the country and one that I represent currently, we have new immigrant populations there, and there's a real need for some of our local, our municipalities and our county governments and our states to recognize that these are also communities that need more access to housing. And especially in an area where, you know, your median incomes are like $93,000, but these families are not making anywhere near the median income of $93,000. And what that means for them in terms of housing is that they need access to public housing, They need access to jobs and opportunity, but they also need access to health care that's delivered in an appropriate way in those places. So I want to close by just sharing with you that I understand as a member of Congress that there's work for me to do. But you represent 25 states, many different agencies. There's work for you to do as well to talk to people like me about the work we need to do. And as we go into these budget debates and appropriations debates, a lot of the things that we care so deeply about, and I know that Dr. Brandt knows this, are in great jeopardy in this process. And so we can't sacrifice and allow to be sacrificed those communities that are the most underserved, that are the most in need, because we're protecting the interests of those at the top. And again, not something that Dr. Brandt can say, but you know what? I'm a politician. That's something I can say. And so I know the challenge that we have, that we face in the Congress when it comes to figuring out budgets, and there are a lot of needs all across the federal government. But if we can't do right by the community of really great people who live in public housing, who need health care, and who need services, then we shouldn't be allowed to go home and sleep at night. I'll just leave you with that. Thank you very much. All right. So since I've actually in my life before Congress, I ran the National Network to End Domestic Violence, and I had Dr. Webb's job of getting everybody together and organizing programs, and then sometimes trying to figure out like what the script should be when you don't always plan it. And so I'm actually used to taking the mic and just rolling with the program. And so here today to roll with the program, I have the great pleasure on behalf of the National Center for Health and Public Housing to present the second annual H. Jack Geiger Awards at this year's conference. And I just want to read you, it's in your program, but it's definitely worth repeating. Dr. Geiger's legacy has been devoted to problems of health, poverty, and human rights, combining community-oriented primary care, public health interventions, civil rights, community development initiatives, and research interests focused on racial and ethnic disparities in medical care. Dr. Geiger has made significant contributions in advocating for quality health care for the less fortunate through work of community health centers. And in his words, these are great words, "The real honor is in having such an award created and named for me, to stimulate and reward the work of others in the future in the ongoing struggle for equity in health care, most particularly for such vulnerable populations as public housing residents." So this year, we are all, and Dr. Brandt is going to join us, in presenting the second annual H. Jack Geiger Awards to the following emerging leaders in the public housing primary care programs. The first recipient is the Houston Area Community Services H. Jack Geiger Award recipient, recognized for excellence in performance improvement.
Here we are.
Yes. You should be here. Don't stay back.
Congratulations. It's great. Great job.
Are they coming through?
Let's make sure we don't.
Congratulations.
Congratulations. And the next award recipient is recognized for significant impact in the areas of program development and analysis, and this award goes to the Floating Hospital.
There you go.
Congratulations. That's great.
Congratulations.
Yeah, good job.
Excellent. Congratulations.
And then lastly, but not leastly, the H. Geiger Award recipient who's recognized for outstanding leadership in program management goes to La Maestra Community Health Center.
Good to see you. Good to see you again. How are you?
Thank you so much. Thank you so very much. Very nice. Where you want to go?
Congratulations.
Thank you again. Thank you.
Congratulations again to all of this year's recipients.
We are so appreciative of Dr. Brandt and Congresswoman. They are going back to fight the cause, going back to work, so thank you for taking time out of your day again. Continuing with our plenary session, I'm happy to introduce my friend Henry Lopez, Captain Henry Lopez, fellow social worker. Henry Lopez is with the U.S. Health Service Commission Corps, is the director of the Office of Special Populations Health in HRSA. In this capacity, he has the responsibility for overseeing numerous national programs which provide primary and preventive health services, including behavioral health to vulnerable populations. He works with our migrant seasonal farm worker program, the homeless program, residents of public housing program, Asian Pacific Islander program, as well as programs for school-aged children. All of these programs provide health care to over 2 million individuals in the United States. Ladies and gentlemen, Henry Lopez.
Thank you, David. Thank you, David. When I was younger, I would take the risk and jump down. Now I have to step down. Well, good morning. How many were here yesterday? Okay, you can be excused. No, I'm just kidding. I'm just kidding. I'm just kidding. I've been accused of having adult ADD because I'm always moving around. And my old philosophy is you can't hit a moving target. That's why I don't stay in my office too long. And talk about pressure. Yesterday we had Dr. Wakefield, our administrator for HRSA. And this morning we had the deputy administrator for HRSA. No pressure for Henry, you know. And so if you all talk to them, please tell them I did okay, please. And the other thing is, because I have a mortgage to pay and I want to keep my job. Dr. Brandt alluded to some good news to look at your clock today. Now, I will say, I can't say nothing either, but please take that to heart. Look at your BlackBerries from time to time, for those who have an interest in doing that. So things are exciting. Hopefully it's an exciting day for each and every one of you. I know in this room, I'm not going to tell them to raise their hands. It's already been an exciting day for them. And no, I cannot, is this being recorded? Please don't. I cannot accept any drinks from anybody, okay? Just off the record, okay? Well, listen, I'm not going to bore you. I'm going to skip through some slides. I'm a Fed and I have 36 slides. I'm only going to show you part of them. So don't, okay, we got break time. All right. Well, you know who is it working? Okay. Uh-oh. I was having this conversation with one of my colleagues yesterday about how things are changing, the technology and all this stuff, and as we get older, we're lucky we've been raised with computers now, but I can only imagine, like my father, I tried to buy him a computer, and I had this conversation with my son. My youngest boy says, we can teach Grandpa how to do this. So I said, go ahead, I've tried. Oh, he's going to do it. So he tried for about half an hour, got it all down, said, okay, take a break, go have some coffee, come back and tell him to turn it on. He couldn't do it. No disrespect to my father, who I love dearly, but it scares him. And so we're talking about senior citizens, we're talking about aging, we're talking about residents of public housing. Same thing. Change scares them. Trying to help them. This is a partnership. So my job is to ensure that you have funding in an effort to keep providing the services you're providing. And one of the things I want to do is expand that partnership that we have going already with the housing authorities. Why is that important? Because there's a lot of people that don't realize they can get care at some of our community health centers. They don't know they can do that. They don't recognize that now that they're homeless and their families are living in public housing, they can go into the community health center that's made available to them. It's always great to hear an elected official like Congresswoman Edwards who is supportive of these programs. We can't do it as federal employees. We can't go to the Hill But what we can do is tell you folks that the responsibility for you is to educate those on the Hill, to let them know what you're doing. If you don't let people know what you're doing, they don't know what you do. So I'll leave that commercial aside. Now, we all know everybody has a mission. But case in point, I always like to say, assuring access to comprehensive, culturally competent, quality primary health care. Some of our facilities, you know that, are brand new, have the latest equipment, have the best health professionals. You know, I had the pleasure of meeting Dr. Morris Konsiki, I think, from Colorado, works in the homeless program. Where is he? There he is. You know, educated at the Health Science Center in San Antonio, Texas, loan repair, and has stayed there with us. That's fantastic. That's the kind of folks we have working with us. You heard this morning Dr. Brandt say we have 19.5 million patients. We know the special populations that I oversee, we see close to 2 million patients. Well, actually, right at 2 million patients, just about. But 173,000 patients that we see are from public housing. Those that identify themselves as from public housing. I have news, too. David doesn't know, but I also have the VA program. We started to take accountability about the VA program. We see over 265,000 veterans that have self-identified themselves as veterans coming to our community health centers. I have been meeting with the VA in an effort to partner with them and collaborate with them. How can we, to ensure that we get services to ensure that the health centers can work and get, somehow work together with the VA administration in an effort to make sure that these folks are seen. You know why they're there? I tell you. Because while they were deployed in theater operations, Afghanistan, their families came to the health centers. They came back, they go to the VA and said, well, we can't see you for another 2-3 weeks, and you have to drive down to our VA hospital 50 miles down the road. And the wife says, gee, the health center's 2 blocks down. Why don't we just go there? They'll see you. And we have a sliding fee scale. So what happens? They start building up. And those are just the ones that identified, because I've learned something. And this is why I put emphasis. We have to learn to say, have you ever served in the military? Not if you're a vet. Some folks see themselves as veterans only if they went to the theater of operation, meaning out there at the war, and don't see themselves entitled to any veteran benefits. But that's not true. So just a little something I've learned. You heard me say yesterday, 77 million patients. That's a lot. That's a wow factor. Come on, guys. Give me a wow. 77 million patients, visits. Come on. One more throw. 1, 2, 3. Wow. Okay. We're spread out of the country, and there's more money to come. I'll get to that. Here's the thing. I'm going to go really fast to that, because it's going to be made available to you on the web, by the way. And if you don't have access, if you want a hard copy, I'll see what I can do for you. It won't be in color because we're trying to save money. It might be double-sided, but that's okay. Yeah, times are hard right now, folks. Okay, if you see newsprint on there, don't disregard it. I'm just teasing. Yeah. The active, just so you know, 33% is the U.S. population. We see 92% poverty. You can see that. It's only on one side. Okay, you can see that. Okay. Here's the thing I wanted to emphasize. Dr. Brandt made mention to this. This is the increase in patients from 2008 to 2010. Now, say, well, what about 2011, 2012? Government's always behind a year in the UDS. We're going to come out with the numbers here in the month for 2011. And then next year we have to wait 2012. We're always behind because we got to collect all the numbers, verify, and all these good things, and this reporting. It's kind of like IRS. They collect the money in April, but you don't know what the budget is until heavens knows when, But the sites, we've increased the number of sites to over 8,100, as I mentioned yesterday. Here's the thing that's important. Jobs. Because of the growth, we increased 18,000 jobs. Here's bienvenidos, my friends from Puerto Rico, Ponce. So 18,600 jobs have been created. We have a focus, like you do. But our focus should be somewhat similar. Primary health care, public health leadership, performance improvement, outreach, quality of care, health outcomes disparity. But the program requirements were really key here. We have a need, we have services, management, finance, and governance. We try to make sure that we are partnering with the community to make sure they can provide access and govern the health center so it adapts to whatever the needs may be. We have, in case you don't know, we have strategic priorities. Grant, did you tell me how much time? You're going to let me know the time, right? Okay. The grantee satisfaction, I can talk for an hour and a half. The external technical assistance training strategy, We have employee satisfaction, timeless quality, impact. We take surveys, folks. We take surveys of the patients that come to our health centers. We make them simple because we want to know if the health center is doing the right thing, and we also want to hear from the health centers if we're providing the right kind of technical assistance, guidance, and whatnot. If we don't work together as a team, we cannot be successful to provide the service to those that need. You know, policy updates. Ooh, this is what you want to hear. Just so you know, recent release policies. Please pay attention to these. We put them, as soon as we develop and they get approved, they go on the web. Go once in a while to the HRSA website and look at policies. You know, some of the things we're going to change, some of the things you may have questions about, don't hesitate. Let us know. Say, gee, you know, this has hurt me. We can sometimes adapt to some of these policies and make some corrections because we're trying to meet the needs of those, and sometimes we miss something, so we want to hear from you as well. We have the sites, the scope, the project, capital projects, process for becoming eligible for Medicare reimbursement. That's a big one. You know, that's coming more and more. Health center collaboration. That's key, collaboration. This is one of the positive things I think that really has come about in this administration. They came and said, you guys are working in silos, meaning you guys being working in government. You know, which is true. I can't even find, I saw a person in my building 5 years ago that I met. Didn't see this person until 5 years later in my own building. Didn't know what this person was doing. Now this person works for me because I didn't know that during the whole process she was working in a department that I always didn't know who was working in that department to get an answer in my own building. So now we're trying to work together. I know it sounds funny, but it's a reality, you know. And then one of the things I want to do, I go to meetings to the VA because I want to be able to contact the same guy or the person who can help me with the answer I want because it's trying to go through a lot of phone calls. FTCA health center policy, the patient-centered medical home, you know, that's important. You know, the electronic health record is going to change. Personal interest story here for me. Unfortunately, I got sick in San Diego because I get treated here at the Navy Medical Center. First of all, I'm public health service and not Navy, so just for the record. But the reality is they were able to tell in San Diego what medications I was taking so they wouldn't give me the wrong prescription to try to fix what was going on with me at that particular time. Okay, and those things happen, folks. You know, they don't, and it's great. And I'm in hopes that that's what happens because our special populations that we deal with in public housing, when we move them from the inner city or urban area to the suburbs, sometimes they leave the suburbs and they come back because they don't like it. They don't have public transportation. There's not a grocery store nearby. Their friends are gone, so they want to go back and sometimes move in with their friends or their relatives. And so we want to make sure if they go see somebody, if they get moved in the interim, they see somebody, we've got to make sure we're in contact and make sure that we give them the right health care. CMS requires all permanent and seasonal sites within a health center approved scope of project be enrolled individually in Medicare. Each site must also indicate its unique Medicare building number. These are initiated and maintain Medicare reimbursement plans. Okay? I want to stop here. Look at this. If you have questions, don't hesitate. You'll have my email address. I'll get you to the right person. Pay attention to these kinds of things. There's a lot of changes coming about. Please ensure that your health center has all the correct medical building numbers and listed. Okay? That's key. Isn't that right, Mr. Hubert? Without that right number, you don't get paid. You get rejected. It's happened, folks. Anticipated policy topics, draft a sliding fees discount program, subrecipient subcontracts, draft quality improvement assurance. And all these, again, are posted on our website. Funding updates. I wasn't kidding when I said I had a lot of slides, okay? We have a spending plan, okay? This is another one. This is what we're going to do, $150 million more for health centers, new access points. That means 200 to 230 awards. Does that excite you? I didn't hear a wow. All right, come on. What is it? All right. This group gets the money. They clap the loudest. No, I'm just kidding. Okay, do I hear a wow? All right. $15 million for expanded services, including expanded HIV services. Guess what? We're going to partner with HIV. Okay, the Bureau, because it's important. Things have evolved to what it used to be with HIV. I worked at a health center in the Army. I'm not going to mention the name, but they put us all the way across the installation because they didn't want us to be with the general population. This was when it first started in the mid-'80s. Now it's evolved to, it's maintained. They can go to the community health center, get the medications. So we're partnering with them. So we're trying to expand HIV services and support for health centers recruitment and retention strategies, including the Health Center for Veterans Hiring Challenge. We're doing all these things with this money because we're starting to expand what we do. We're being more visionary. $20 million for health center control networks. We want everybody to talk together. We can have a system, but if you don't have the right system, it doesn't connect. $600 million for capital development building capacity. All right, this table gets some money this time. Yeah. Don't be surprised next year we're here. He said, "Who got money?" They raised their hands. Okay, don't get disappointed. It's $100 million for capital development, immediate facility improvements, $75 million for school-based health center. This money's going out, folks. Be ready.
It's already on the website.
Again, please, you can't buy me drinks today. Okay. Congratulations to those. As I'm speaking here, messages are going out, okay? You see some people jump up and, all right? And so my staff here is sitting in front of me, and I'm going to introduce them before I close, because they're here to protect me in case somebody didn't get any funding. No, I'm just kidding. Here's a continuing funding opportunities. 2012 budget period progress report, technical assistance. Here's the thing. I mentioned this yesterday, and for those who've heard me speak, I'm always preaching this. Don't be afraid to ask for help. Our job, believe it or not, trust me, I'm with the government, my job, and the team that works with me, the guys that really do all the work and make me look good. Where's my photographer today? No pictures. Oh, there he is, he's sitting down, okay. Their job is to make sure that they ensure that you're successful. Because we want you to be successful so we can get the money out there for those in need. We didn't get this money because there's not a need for it. There's a tremendous need. You hear this all the time. As the economy changed a few years back, it changed the whole demographics of residents, of homeless people. The neighborhoods change. Everything is changing around your neighborhood. You heard Congresswoman Edwards mention some of her neighborhoods now are different. That's reality, folks. So we've got to make sure we have health care available to these folks. We have the 20 service area competition, cooperative agreements. This is where North American comes in as others. We have state and regional primary care associations. Sometimes I tell, yay! We work in partnership. These PCAs, as we call them, they're there to take a phone call. If you're in a community and say, we really need a health center here, and the plant closed down, we have people here, we have the poultry industry built a brand new poultry, we have people coming in, they need health care. How do we get a health center built? How do we qualify for something like that? Contact Jim Hunt. I'll give you a cell number and home number in a minute. But you contact him because the PCAs across the country are there to help you as well. And they work with us, and their job is to make you successful. And their job is to work sometimes with the local state legislators in an effort to make things happen. Quality and data updates. Do I have time? 2 minutes, okay. Patient-centered medical home, health home. That's the N word. You know that. I'm going to bypass that because we know what we have to do. We all have to have a home so we can make sure we're taken care of. My father has a home. I use my father as an example because he only goes to one doctor, and when Dr. Gonzalez retired, and he says, I'm going to take you. So he met him at the new doctor's office because he wanted to make sure that this person that was going to take care of him now was okay. Okay, so Dr. Gonzalez passed him to Dr. Torino now, and Dr. Torino speaks Spanish, and that's okay for my dad. Okay, fine, you must be okay because my other doctor said you're okay because the other doctor retired, because doctors do retire. FTCA policy, just so you know, again, I apologize, I got 2 minutes here, I don't want to take Jim's time. UDS reporting, got to do that, folks. We need those numbers. Treat it like a business, as you do, even though you deal with the government. Proof is in the pudding. They need numbers. Without the numbers, we don't justify our sexing sometimes. And it's getting more and more. And these computers, boy, they really say, how come you don't have a system? So we're trying to assist you to make sure that the numbers are complete and corrected. You know, and we added things, new clinical measures, coronary artery disease, colorectal cancer. The reason we're adding these things because there's a need out there. We see the numbers rising, so we want to make sure we take credit for what we're doing, what you're doing out there to provide the services to those in need. Okay, technical assistance we serve, you know, national cooperative agreements. We have the primary care associations, primary care offices, those individuals that work with the local state health department in an effort to work with the state. We have federal TA, we have project officers. On that note, we have Mr. Kevin, our Lieutenant Commander Kevin Bates. Right, stand up, Kevin. He works in our office as a project officer. We have Mr. Chris Perry, Project Officer of Public Housing. I have my senior advisor who's been around for many years, like myself, you know, Hubert Abat. This is just part of the team of the 21 people I have now that make me look good, you know. And the nice thing about having Hubert, he says, Henry, I'm going to make you look good today. It's okay. So primary health care helpline. I'm sorry about this, but thank you. I always go over time, so there's no time for questions. Just kidding. I'm easy to spot. I'm here all day. There's my email. There's my office number. But more importantly, again, I always give out my cell number, 703-861-0700. People say you're crazy. No, I'm not. If it's important to you to contact me, it's important for me to respond back or have somebody from my office respond back to you immediately. I might be in travel, as I do a lot. I'm out of the office. I get these emails. And I have people here in the audience who know I call back. Raise your hands on the weekends. Dr. Page, Henry Tuttle, back there, Michael. They know I call on the weekends. You call me at night, I'll call you back. It's important. That means you have something that really needs to be answered. And time sometimes is money, folks. With that note, thank you so much for your time. Thank you for what you do. And for my dental friends, as Dr. Weir say, only brush the teeth you want to keep. And thank you for not smoking.
Henry, it's always a pleasure. Thank you so much. For those that haven't met Henry, please take a few moments out of your day to sit down and talk with him. Tell him about your project. Tell him about what life is like there. It's really important that Henry understands the reality that you guys are facing so he can bring it to work every day. So, Henry, thank you so much. I am pleased to introduce Jim Hunt, who I believe is now Dr. Hunt, correct? Dr. Hunt, yay. And for those that don't know Jim, Jim has been in the health center world really since the first day of community health centers. He is a leader like you can't even imagine, and we are really privileged to have him at our table and taking time out of his busy day to talk with us. So I don't need to read his bio. It's in there. He's great. I want to save the time so he can actually talk.
Thanks, Dave.
Thank you.
Wow, thanks everyone. As you can see, my presentation today is a historical overview of community health centers, but I think I've renamed it after listening to these fabulous three speakers before me. I think I'll call it Random Thoughts from the Podium, because I'd like to comment more on what they said than on what I intended to say. I'll weave in a little history, and I'll try to get us back on schedule if I can. So obviously, Congresswoman Edwards spoke about the need for advocacy. Secretary Sebelius, Drs. Wakefield and Brandt, Jim McCrae, and our dear friend Henry Lopez are all there as part of the team supporting us, and we need to support them. Both of us, Henry and I, are celebrating. Don't we look younger this week? We're both celebrating that both of our sons passed the bar, so we basically are free. And that prescription he was looking for, my wife said in San Diego, was for hair, because Henry's hair and my hair started the same, but he joined the federal government and I stayed with the health centers. They used to call me the follically impaired one. You know? Enough on that. I just finished my doctorate, and I did it on the history of the health center movement and the Reagan block grants turning back activity to the states. Isn't that comical? And Congressman Davis was one of my members of my committee, and I must say the toughest member of all, holding me to task and forcing me, as he does so well, to address the issues head on. But our movement has a rich history, and that history is of struggle and success. We continue to struggle, but we continue to have success within those struggles. So as you struggle with lack of resources and challenges on the home front, just know that those before you had those same struggles and were able to be successful through them. We were searching and in the searchlight looking for resources and recognition and respect for many years. Today we're in the spotlight, and that spotlight is in the growth through the ACA that's already been talked about, and also in the growth of our patients served, and I'll get to that in a few minutes. But one of the things that I think the Congresswoman and Dr. Brandt alluded to, Henry certainly does it well every day, and that is that you and I and we need to tell the stories. The data is extremely impressive, really important for our quality and our access. But when you get in front of those legislators, or you get in front of that city council person, or that congressman or woman, it is the stories that count, how we've changed lives, how people have been assisted in their own growth through our work. And over the years, that's what leads to the success. The data is important, the quality is important, the stories are equally important. How many of you have, and welcome to my Massachusetts colleagues that are here, have visited more than 10 community health centers? Excellent. 5? Okay, and the one you're in, or the public housing? Well, just remember that our colleagues throughout the nation all do different things reflecting their communities. And I always like to say, and it's the first Geigerism that I'll bring to you today, and that is that if you've seen one community health center, you've seen one community health center. So as you try to reflect the essence of your communities, understand that collegially within states or within special population groups or within the nation, we all stand together as a movement, but each one of you is separate and unique and very important. Our movement is a family. It is different than a business, although the business principles that we practice are extremely important. As a Primary Care Association director, it is my duty to bring you the shameless commercial messages from Massachusetts. Some of you may be suffering from Massachusettsitis. That's hearing too many times how Massachusetts is the example of the nation. But the first community health center started in Massachusetts. Today, our not-for-profit community health centers expand the whole state, 50 of them in total, and 800,000 people served, and we'll get to that in a minute. As Henry just told us, 8,100 sites across our nation now practice community health. Almost 20 million people served. In Massachusetts, 800,000 people served through over 280 practice sites. You all know about the broad array of services we provide and continue to provide. But it's really important that in the 21st century we begin to leverage those. 17 of our health centers had electronic medical records 10 years ago. 49 out of 50 have them today. Leverage state resources, private resources, a little bit of borrowing here and there, a tin cup banging asking for resources from our hospital partners and others, and a big stimulus from the federal government. The reason I like to include this slide is not only to cite that, but on the bottom there you'll see that in Massachusetts and across the nation we have become big. It's not good to be small these days. We have 14,000 people supported in jobs in Massachusetts and about $1.5 billion in economic engine-driven resources. In my state, some of the mill cities, you've cited the health center and all of a sudden the bank appeared. You cited the health center and the pharmacy appeared. The pharmacy and the bank followed by the supermarket. Entire communities re-energized by the anchor of the community health center. That's happening in your communities too. It's really important that we describe how big of an economic engine we are. So in Massachusetts, we have all of our growth outside of the big cities. The big city of Boston, the cities of Springfield and Worcester are now being equaled or surpassed by those who travel to find housing, who travel to find jobs, who are conclaves of cultural and ethnic groups. The city of Lowell Health Center served 8,500 people 20 years ago. Today, it's building a $30 million complex. The city of Lynn, the health center is the largest employer. The cities of New Bedford and Quincy, Henry Tuttle is here from Quincy. Health centers have become a focal point of jobs, of creation, of action. And over the last 12 years, all the growth in Massachusetts has come from outside the city of Boston. What's interesting is not only have we become the largest primary care network in Massachusetts, but as Henry just told us, with some 1,300 sites across the country, soon to be 1,300 grantees across the country, hopefully in the next couple of months, we have become, community health centers, the largest primary care network in the United States. The largest primary care network in the United States. So you all know what we do, and you know how effective we are, and you know how much work there is to be done. You know that our collaborations in concert with public and private partners are important. Hospitals and health centers working together can create an interoperability where that electronic health record can follow that patient regardless of insurance, regardless of site, returning the patient back to the medical home, as Henry and Dr. Brandt have all taught us. Geiger and Gibson saw what was happening in an isolated peninsula in Massachusetts and decided that this was wrong. Tufts Medical School was using that peninsula as a medical research site and a training site for its residents. And although services were being provided to the 1,503 housing units that housed over 5,000 people, they saw that 3 hours of bus changes to get to our city hospital was not appropriate. It also happened to be Columbia Point in the then Speaker of the House's, John McCormick's district. Didn't hurt. Geiger had gone to South Africa during the apartheid and worked with Emily and Sidney Clark on developing health centers in South Africa. They had developed 16 of them. Geiger worked in the Lamontville project, which was a Zulu tribal nation, and thought that his life work would be in community health centers and global health internationally, probably stationed in Africa. But then during the freedom marches of 1964, he, Gibson, and many other physicians on the Physicians Organization for Human Rights went to the South. And he discovered that the poverty and the need was right here in America. And that if we were going to be an example for the world, we had to focus on what was happening right here. Meanwhile, President Kennedy was supporting the civil rights movement in its beginnings. The great Dr. Martin Luther King was leading the marches. Geiger, Gibson, and many other physicians were taking care of the wounded. And he fell upon an isolated county. Anybody from Mississippi? Anybody from Delta? Delta Health Center? Anybody? No? Mississippi, though? He found an isolated hamlet in North Bolivar County, about 90 miles south of Memphis, along the Mississippi Delta, called Mound Bayou. And at the time, he knew he couldn't propose to the incoming Johnson administration that was implementing many of the visions of President Kennedy. He knew that it wouldn't fly to propose a health center empowering poor people in Mound Bayou, North Bolivar County, Mississippi, and instead said, well, why don't we go to Speaker McCormick and to then Sergeant Shriver, the head of the new Office of Economic Opportunity, and propose two sites, one in this isolated peninsula in Boston, along with one in North Bolivar County, a rural, isolated site in the south. So those two pilots were the first health centers funded. 1965 at Columbia Point, and 1 year later to the exact day in Mound Bayou, Mississippi. Remember, President Johnson stood, and as a symbol, he said, "We will conduct a war on poverty." And many forget the second line of that, and by that create a great society. And therefore, many of us who skipped 10th grade and didn't study civics missed it when they said the Great Society programs included jobs, community empowerment, the creation of access to health care. We forgot that, in fact, the war on poverty was not to eradicate poverty solely. It was to take poverty and craft it into a great societal effort. So that's why I like to use the war on poverty as the symbol of what Geiger and Gibson felt. Columbia Point was, in fact, where he first saw it. And right after the establishment of these first health centers, Geiger began to write extensively about what he called the Schweitzer bit, which I think Albert Schweitzer wouldn't be pleased, but he called it the Schweitzer bit, of actually treating and streeting people when they were profoundly sick. So people would wind up in emergency rooms. They would get treated in a fragmented way, and probably quite well, frankly. They might wait 8 hours, as they do today, but they might be treated quite well. And then they would exit that emergency room, and you wouldn't see them till the next acute episode. Geiger thought that was wrong. He said we have to create an empowerment because the poor get sicker and the sick get poorer. So if you've got a child with malnutrition, if you treat just that child, then the rest of the family remains malnourished. So you've got to create an avenue where that whole family is uplifted by the care that you give. So that's why he dedicated his life's work. And Jack is now 88 years of age. He's doing much better. And he basically is able to get out and about, although his eyesight is very challenging. And he asked me to make special mention to you of his thrill at having these awards named in his honor. He urged me to urge you to interact with these awardees to get their essence and get their story. And someday, he says, I will join you at this conference if I'm able. And he continues to be the fire and brimstone that he always was. Just a few more. So the key to this slide is that when the medical schools established the health centers, understand that the OEO, the federal government, were the ones that said you must create an avenue of maximum feasible consumer participation. Maximum feasible consumer participation. Okay, what does that mean amongst all these acronyms? What it meant was that those that were to be served had to have a meaningful role in those programs. Another program that was started around the same time that shot like a rocket in 1965 was the Head Start program. We had the United States Public Health Service Corps, and the origin of Head Start was that they wanted to name it the Kiddie Corps, because we were establishing the Jobs Corps, and we had the United States Public Health Service Corps. Let's call this the Kiddie Corps. And Sergeant Shriver said, no, no, no. For maximum consumer participation of parents, we should invite these parents in. Not that these children are joining some military organization, but in fact, they are going to get a head start because our war on poverty to create a great society requires it. So the hope was that the community-based model of care would lead to structural reform of the United States medical system, and I'm here to tell you that it has. That it has. We have made a profound impact on the American healthcare delivery system, and hopefully we'll stop using the word healthcare in the future, and we'll be talking about the health of Americans rather than the healthcare that we bring to those who are residents of our country. So Founded in '66, the Delta Health Center had this vision of a complete model of uplifting the community. So for those of you who have seen the documentary Out in the Rural, and if you haven't, I would urge you to go to my website, and it's posted on my website. It's a 26-minute, if you will, advertorial for community empowerment, done in 1968, featuring Dr. Geiger. It speaks to the need for a food co-op, of job creation, of education, of making your own healthcare providers by sending people to nursing school and medical school, by getting people GEDs, to stop them from exiting to going up to Michigan to be in the plants and stay on the line. There's one person out in the rural that says, my brother went to the line, and in 27 years he never moved a single inch on the line. Why can't we create jobs in this county so that people can come back and uplift themselves out of poverty and create, if you will, that great society? So community empowerment was both a central theme in Boston and in Mound Bayou, Mississippi. I believe it makes us different as community health centers, healthcare for the homeless programs, healthcare in rural, HIV programs, community health centers, and healthcare and public housing. I believe it makes the difference for us. I believe that we should continue to empower our boards and grow our boards. Just 2 Jack Geiger stories, and then I think I'm almost out of time. First, those community boards are critically important. So in 1967, as Geiger and his team were being called on the carpet, and he needed more money for Mound Bayou, he was being called on the carpet by then Julius Richmond, who was the head of the healthcare programs for OEO, who became the Surgeon General, and Sergeant Shriver, who, as many of you know, who are at least aging boomers like me, was the brother-in-law of the President of the United States, John F. Kennedy's brother-in-law. He was called on the carpet to answer as to why they were buying food for poor people with prescriptions, and why they were buying farm equipment with the grant being given them by the Office of Economic Opportunity for Health Care. So he decided to take his board, and his board was headed up by Reverend Biggs. Reverend Biggs was a local minister in Mound Bayou, and the board all assembled, and they went down and got on the plane in Memphis, and Reverend Biggs announced that for the 16 board members who were on the plane, it's the first time they had ever been on an aircraft. They were a little nervous. So as the plane was taxiing out to the runway, all 140 people aboard, 16 of them the board members of Delta, Reverend Biggs began to offer a prayer. Reverend Biggs then broke into song. The gospel music landed until they landed in the nation's capital. They headed up to the Hill. Sergeant Shriver came in with Julie Richmond and his team. And Sergeant Shriver said, well, let's begin the meeting. And Reverend Biggs said, excuse me, we have a tradition where I come from that we begin meetings in prayer. And so for the next 35 minutes, Reverend Biggs prayed for forgiveness for the misuse of the grant, prayed that Sergeant Shriver would see the light and further fund the health center to do the good work it was doing, and prayed that the federal auditors would not visit Mississippi soon. Meeting over, case closed, do good work and prosper. So the moral of the story is that our stories are critically important. John Hatch, who was the social worker head of the Columbia Point Health Center Task Force, was studying the impact of Columbia Point and asked Geiger if he could go to Mound Bayou in advance of the Geiger-Gibson arrival. They started with a trailer. And so he was granted permission to go and flew down and disappeared for 2.5 weeks. They thought something had befallen him, this African-American giant man from Boston, Massachusetts, with a Yankee accent heading down to Mound Bayou. But finally he surfaced, and he said he spent those 2 weeks in an indigenous embedment in the population served. I said, what's that? He said, well, I picked cotton during the day, and I went to church at night. And I went to every church where the empowerment was, where people had roles in the church, where there was gospel music and singing and uplifting and empowerment, and that's what I did. And during the day, I wanted to feel what the people felt. So I did that for the 2 or 3 weeks where I was missing in action. The first day that Mound Bayou opened, it had 6 patients. On the second day, 25. And by year end, lines out the doors trying to get the care based upon the word of mouth of respect, integrity, access, and primary health care. So today, with all the health centers we've got, it's really important that we reflect on what happened in Boston and Mound Bayou, what happens in your local communities, and to tell those stories that are so important. That now nearly 2,000 health centers serving 20 million patients. So you've heard the stories about error in public health. You've heard the stories about capital development and workforce. You've understood that presidential and congressional elections are here this year. No one in the federal government can speak to these because these are partisan elections, and you can't speak to them from your health centers in a partisan way, but you can tell the stories and push back on what ERA has done for jobs, what ERA has done for access, what the ACA is doing today. You can become a part of your primary care association, very important. I urge you to join NAC, our National Association of Community Health Centers, that is telling those stories on the Hill every single day, fighting for our HRSA colleagues and the programs that they and others support, ACA being the #1 target on the agenda. This new word that we're all facing, sequestration, is something that's going to be coming to a city or town near you. And for those of us who say, well, we're exempt from some of those cuts if the Congress has to cut, remember, if everything else is cut, we're going to be cut too. If that source that you have that's bringing you resources that leverage what you do, if that's cut, you're cut too. So supporting the congressional efforts to find a settlement where the most important, if you will, entitlement programs are protected, and the most important discretionary programs like the health center programs are protected. And then finally, just very important that we protect ourselves and that we learn about these 19 program requirements of HRSA and the Bureau of Primary Health Care, that we educate our staffs, big and small, in these 19 program requirements where need and services and governance, quality become really, really important, and that we understand that we need to protect ourselves by doing so. So thanks very much. Why don't I stop there?
Oh, Henry, thank you. I would like to first of all thank all of our plenary speakers, Congresswoman, Dr. Brandt, Henry Lopez, Jim Hunt, and our moderator for this morning, David Vincent. I think they did an awesome job, didn't they? Thank you. And Jim Hunt's presentation was really one that we thought was important for you to understand, the work, where it started. The community health center is really the heart of most communities. And there's so much that we have, because of the work that you do, the dedication, the tireless hours, there's so much help and movement and job creation and education. There's so much done through the work that you do. So thank you for that. As Jim mentioned, the 19 program requirements, that's one of our biggest charges from HRSA to make sure that you have, that you meet them, and we are going to help you successfully do that. And so as we break now, for the next couple of minutes, we ask you to meet in the various workshops, rooms that are scheduled for workshops. I think we have something that addresses each of those 19 program requirements over the next 2.5 days. So really encourage you to go to the workshops and receive the information that you need to take you to the next level. So again, thank you all for coming today, and we will convene for workshops at 10:45. Thank you.